Obviously, whoever when you do this should be an appropriate PPE, just like we saw at the beginning of the video. That trained observer was geared up. All right?
So you're the trained observer.
We're going to take off our gowns by gripping in front of them,
Oh, you're just watching, making sure.
pulling them away from our bodies. These are made to break. Made to break from the back.
Do you want us to break them? Or are we going to use these again tonight?
Hard.
Breaking these? Breaking them.
Back. You're pulling too far from the chest. You're pulling from up here. It's separated.
If you want to stick this up a long time, you can tear through that tile.
As you remove your gown, remove your gown, it's coming off, you're pulling your arms, you're pulling the gown inside out. You're going to roll it up.
Clean, clean.
Again, your hygiene. That's what they do on the video. Sounds good to me.
We really got to stock up on here.
All right, finally, we're going to remove our N95. We're going to take the bottom strap first, pull it up over your head. Now you're going to take the top strap, pull the mask so it pulls away from your face. You should be leaning forward as you do it.
That feels a lot better.
And take a deep breath.
Much better.
One more time, hand hygiene. Using our gloves. All right, at this point, we're going to take off our inner gloves. All right, hand hygiene on your, and then hand hygiene again on our hands. We're going to put on another set of gloves. Another new thing. We're now using 3 sets of gloves. Because what on you was still contaminated.
Your feet?
It's probably still contaminated on them. Our boots. Because as we're taking all this stuff off, right, we're stepping in it, we're stepping on our gown, pulling on our boots. So at that point, we're going to step into a clean area. Right, using a disinfectant wipe, and we're going to clean our boots. Right, wipe down our boots. So finish down the clean area. Got a disinfectant wipe. Clorox wipes work pretty good.
Just use an MSS basin. Sterile water, bleach, do the Doctors Without Borders way.
At that point,
It's not a bad idea,
last
right?
set of gloves. And then one last time, right? What are we going to do at that point? You can do the hand, right? You can do it again with the hand sanitizer, or you can go to the sink and wash your hands. Right. Any questions on donning fecal isolation kits?
Now, what other you ask somebody, I guess your partner helping them drop in
Yes.
every time that you drop the sanitizer, you might.
The sanitizer becomes contaminated. Yes.
Yeah, but when you take the glove the first time, you're gonna use the sanitizer, and then
The
the
best-
second time the same sanitizer, then the third time the same sanitizer. So when you're all done, you're gonna use the same bottle. You touch it. So you're gonna have.
You're going to want your partner
Yeah, so we used to be
to
the
be
one.
doing this. All right.
Okay.
You're going to want your partner. He's going to be geared up, right? Hopefully, if you were dealing with this patient, right? Let's say we had a really bad call where we had a patient, right, infectious patient. Let's say he had TB, and we had to do it was a cardiac arrest. We have a lot of people on that call, so it may not necessarily be me and my partner because we both work on the patient. It might be that second BLS unit that arrived, and they're going to help us decon. Right, or it's going to be that conditions boss that came in. He's going to help us decon. Right. In the end, you're going to want somebody that didn't have direct patient contact to be the one to help you do the decon. Because they're going to be the one holding the hand sanitizer and doing it because they're clean. Right? They're going to stay geared up because they're going to have to touch you to help you get this stuff off. Right, that's kind of where we're gearing towards. Before, we always taught our guys, even with guys, particularly with the isolation, that you do it on your own, right? Right, we weren't helping each other out. Now the idea is that you help each other out. You have someone that stands, that wasn't involved with patient care, and they're helping the decon.
But I would just say the idea is to minimize that person's touching you, so if you can avoid having them untie it, pull it off, it's safer to avoid having that person touch you. They should be in wearing the gear also, but if they avoid touching you, then they're minimizing their risk also.
That's where I think I got
So, you know,
I
I
had
think
them back
like
to
having
back.
the buddy or the observer,
That's what got me. And I just,
be the one to provide the hand sanitizer, however the setup is, or it's gonna be different depending on different companies. That's probably better than, you know, have what you mentioned. And then the other best practice that we're recommending in the hospitals is that the person who is the observer / buddy that's like walking you through it will actually have the checklist that you have, read the item on the checklist, but the person who's taking the stuff off does not do anything until the person finishes reading a sentence, and then after you finish reading a sentence, you watch the person do it. So it slows you down a lot, and you're uncomfortable and you want to get out of that stuff, I know, but that's really how you can make sure that you're not making any mistakes. So it's like, you know, Joe says, okay, perform, you know, glove sanitize, you know, glove hygiene.
Yeah.
Then you put your eyes on them while they perform the glove hygiene. And then if they try to move to the next step, you say no. You read it and then you go to the next step.
Also, we're huge fans of the automatic dispensers, where I know that's probably not practical in your buses, but if it is in any way practical, like the automatic dispensers, I don't think that would be
But if you do end up,
That recommended in the law,
Yeah.
it's less for you to tell.
hot. We've also done stuff in the hot, warm, and cold water out. So we're using a different bottle for your safe at the doctor.
But some of the hospitals are using the wipes in place of the actual liquid.
but it's advisable if you do end up, if you're contaminated and you do end up touching the Purell bottle, just to red bag the Purell bottle when you're done with everything. Anyway,
Absolutely.
Yeah, you want to red bag it, and then at the end,
clarify.
make sure when you're at that last part, because all the way up until that last part, you have gloves on when you're touching anything.
Right.
Right, don't use that same Purell bottle.
Yeah,
All right, yeah, you know, and then you got the dirty Purell bottle.
right.
Throw that in the garbage and use something else to do that final cleansing of your hands. Back and look at TV.
yeah, I just had a question about eyeglasses. Is there a standard for when you should, because I noticed my eyeglasses got caught up in everything, so, and they're right near your eyes.
So, I mean, the real answer to that is that if you have glasses, you should be using a full face air purifying respirator that has built-in prescription lenses. I know that that's probably not the way that any of this works. I know I don't have any employees where they've asked for that we've gone through it, but if your glasses are gonna fog up, it's gonna impede your vision, so.
So is it
that
recommended-
is the recommended answer.
Would it be recommended to wear contacts over glasses then?
I mean, there's, the issue with contacts is the absorption and absorption properties of them. I mean, this is not necessarily a chemical response, so that's not as big of a factor here. The best way to do it is with the full face mask.
If your glasses were fogging up.
Well, it was also just getting caught up and everything, right? So they're gonna get dirty. So it's in a sense part of the equipment that has to get
Yeah,
dealt with.
the biggest thing with glasses that I've seen on the bus is that generally, like, you want to wear a size bigger. So if you have a standard size cap, get something a little bigger, because it just gives you more room to play with. And then you just got to be a little more careful to pull things down and away. So one of the things, if you're just taking the cap and you're pulling it up, right, you're going to get snagged. But if you grip the outside of it, down and away, and then around, right, you'll find your cap won't get caught. And then the face shield actually is kind of meant to sit up above where your glasses are, so that shouldn't be getting in the way too much of it. If you got goggles, obviously, that's gonna cause issues. You should never be using goggles, you should be using the face shield.
All right.
Does that answer your
Yeah,
question?
it does.
Yeah, and I would just say like the take-home point is practice. Practice, because I think in addition to like the two things that you mentioned that may have been problems with nurses in Dallas, I think using equipment that you're not familiar with, that you haven't practiced on, puts you at higher risk.
You got a question here?
Yeah, you mentioned docking in Huntsville. You wouldn't be docking in Huntsville, you'd be docking in the warm zone.
I said a hot zone is actually, it's a zone that's dedicated for where you're taking off the dirty equipment, and then you're gonna be stepping into a zone where you shouldn't have any contaminated equipment on you anymore,
Yeah.
right? Hot zone is probably the worst phrase I could have used.
No, I
it's
actually-
the- It's the right phrase. CDC guidance is to dock in the hot zone. And then you're stepping into the warm zone, you're on your hot chair, and then once you have the duty covers off, then you're stepping into the warm.
Last question in the back, and then we're gonna keep
Well,
things moving forward.
To help out the issue, because I have glasses, and when I did hazmat ops, I had,
Jerry, could you
Sure.
speak up just a little bit?
well, when I did hazmat ops back years ago, I had the APR on, but also what could help, if you don't have that available, is the escape hood, because you don't have that elasticity, it's pulling constantly at the back, it's coming in from a different angle, so it won't pull your glasses off in the same manner. So that's an option.
Thank you, Jerry. All right, guys, so like Dr. Quinn had said before, right, we had some issues putting the stuff on and off, right? Right, didn't quite go cleanly for everyone. That's what happens when you don't do it every day. So just, we want our course of practice. Should be doing this at least once a year for you guys. Let them throw this stuff on, right, and then take it off, see if they're able to do it in a manner that doesn't get them contaminated.
Once a month, right?
All right, currently the guidelines is to do this training once a month. All right, that's what the health order has said. But I'm talking about general isolation. Once we get past Ebola, right, you should always be doing this kind of training for your providers. So we'll take a break from Don and coffee for now. All right, Marie, you're up. How much you want?
Hi, everybody. My name is Marie. I know that you all have been hearing about Ebola probably since before the summer. There was chatter about Ebola from the CDC and WHO since earlier than that. And this is not the first time we've had an outbreak in Africa. I know I remember from 1976, that was the first ones. And what we're doing tonight is just to let you know how Ebola, what it is, how it can be transmitted, and to keep you safe, but not panic stricken, because you wear PPE the right way. You're really protecting yourself, your crews, and your families. What have you heard about Ebola? Anybody have anything that they've heard that stands out in their minds? Anybody watch Fox News? Anybody here panic stricken? Okay. Well, you've been hearing it for a long time. Okay, we're going to watch a quick video on how the Ebola virus actually works.
Everyone knows that Ebola kills, but what exactly does it do? This worm-like virus has a devious way of working. Once it gets in the body, the virus attaches itself to the surface of the cells. Then it invades them, replicates, and causes the cells to explode. sending infectious particles flying. From there, Ebola overpowers the immune system. It uses the very cells that are meant to fight infection to travel to other parts of the body, including the liver, spleen, kidneys, and brain. It attacks almost every organ and tissue. The particle explosion also sets off an overwhelming inflammatory reaction. That's what causes the sudden flu-like symptoms that are the first signs of Ebola. Inside the blood vessels, the virus causes abnormal clotting and bleeding at the same time. Bleeding into the skin causes a red rash that appears all over. With the ability to clot normally destroyed, bleeding occurs internally as well as from the eyes, ears, and nose. This whole cascade of events causes the organs to fail. The loss of blood, along with organ failure, is what makes Ebola so deadly. But if doctors can keep the organs working with intravenous fluids, blood transfusions, a ventilator, and other treatments, there's a much better chance they can save lives. The infection moves fast, and it can kill in 1 to 2 weeks. In the current outbreak, 60% of the people who caught the virus have died. Many more could likely be saved with better access to medical care. The risk of catching Ebola is extremely low in the U.S., and officials are working round the clock to make sure it's contained. For WebMD, I'm Dr. Michael Smith.
Okay. So let's just go to the next slide. So as you see, the virus replicates on the cell, then goes into the cell, explodes it, and goes throughout the body. And it affects, for the most part, the linings. That's why you get a lot of bleeding. You have to deal with the cells. Okay. There are big questions about Ebola virus being airborne. How many people think it's airborne?
Show of hands. So we got 2 that say yes, it's airborne. How about no? Who thinks it's not airborne? Majority of the room.
Why would, I mean, it's a good question because I've questioned it myself. If I'm standing next to somebody with Ebola and they cough on me and it happens to go through broken skin or if I make this many things, have the potential. But it's not an airborne disease because it can't, the virus can't travel that far. So you're not, yes?
It's considered a droplet risk,
Yeah,
right?
it's a
Like
droplet
tuberculosis, right? But not like
It's not-
across the room.
No. Well, that's why when we set up, well, not us, the Department of Health and CDC set up the re-interview guidelines for you to stand away 3 feet. That's considered a safe distance to interview someone who's suspected having Ebola. Did you have, you want to add something?
What about somebody, who's suspected of having the Ebola virus sneezes? You know that the sneeze that travels a good distance, more than 3 feet. What are we doing, what do you suggest?
So, this particular virus is the evidence that we have from many outbreaks that have happened since 1976 in Africa is that the epidemiology of it is that the people who get infected are the ones who have very close direct contact with people who are very sick with the disease. So that's why we understand that it spreads mainly by contact. There's a theoretical risk that it could be spread by droplet if you're standing in very close proximity to someone. That's why the recommended infection control precautions are standard contact and droplet. Droplet is added because of that potential risk, although it's not borne out in the epidemiologic studies. And when we talk about airborne and airborne transmission, that really refers to like a disease that could spread from me to Marie. Like smallpox, like measles, I could be in a room with measles and you could come in a few hours later and you could still catch the measles from being in the same space. That does not happen with Ebola. So it's not considered to be airborne. I think there is this kind of theoretical risk that if you're doing a procedure that causes aerosolization of the virus, that someone who's in close proximity to that aerosol generated procedure could become infected that way. And that's actually the reason why CDC is recommending the N95 respirator or the powered air purifying respirator when you're doing an aerosol generated procedure, like intubation, like providing nebulized treatment. Now, hopefully you wouldn't be doing that in the field, but you never know when you might have to. So that's why you're including the N95 respirator in the suite of personal protective equipment that we've chosen.
Yeah, on the REMAC here in New York City, has said that if you have a suspected Ebola patient, you're not going to be intubating, you're not going to be doing aerosolized procedures just for that reason. We did the same thing when we had SARS.
SARS can be airborne.
SARS is, yeah. Okay, so we're going to look at a case, and we'll have you decide whether you think this is a suspected Ebola. Okay, before we go to that, we'll know that the questions that we ask are, do they have a fever? And or do they feel sick? Do they have flu-like symptoms? And have a travel history? What are the three countries?
Sierra Leone.
Yeah, just memorize those three names. And, okay, so we have a 4-year-old boy who has visited Liberia. He developed flu symptoms 2 weeks prior to returning to the United States. He took metfloquine, and that's a medication for malaria.
Yeah,
Another
Flockwin.
disease in West Africa. He still had his fever on flight. He was taken to the hospital by EMS. He had a fever of 103.1, with headache and abdominal pain, no bleeding, vomiting, diarrhea, or rash. So how many people think that this patient may have suspected Ebola?
Raise your hand if you think, yes, this kid probably has Ebola. Got 1, 2, 3, 4, 5, 6, about a third of the room, 7. All right, raise your hand if you think he does not have Ebola. All right, so Daryl, why don't you tell us, why don't you think he has Ebola?
He's been alive for 2 weeks with the flu, so the incubation period is prior to that, and he's been existing with the disease and hasn't progressed beyond the flu.
I see, so why is it that 2 weeks sticks out in your head, and, all right, you can't have Ebola for 2 weeks and not be dead yet?
Well, he hasn't developed any other symptoms other than the fever and the flu.
Okay. All right, who else didn't think that he thinks he doesn't have it?
Was it the omission of bleeding, vomiting, and diarrhea and rash not present at the time?
Okay.
After the 2 weeks.
All right, who thought he did have Ebola? Why?
You always have to suspect, it's coming from Liberia, and you have to suspect. You're never gonna know that he indeed had the virus until you detect that. You have to be cautious and suspect.
You can develop symptoms, once the incubation period is between 2 and 21 days. So 2 weeks does fall within that 21-day period. And you have a history of travel from Liberia, and you have fever. So to be on the safe side, this is a patient that you would suspect to have Ebola, and then give a call to the Department of Health and let their experts decide. So we have to err on the side of caution.
Based on a policy, we would treat him
As a result, yes. And those are the directions from the CDC and the New York City Department of Health. You want to add anything?
No, just that this case meets our reporting criteria.
He has some things that tell us yes, and he does have some things that tell us no. Darryl is right. You know, he's been sick for 2 weeks. Most of all the patients within 2 weeks, they've either gotten better or they haven't made. You know, and he still has some fairly mild symptoms, so that kind of tells us no. But he has a lot of things that tell us yes. We're going to err on the side of caution. It's not always going to be clear.
Which is not one of the confusing questions.
Those were also the same signs and symptoms of malaria, and very dangerous.
Exactly. So he could have malaria. Most likely, he probably has malaria, but we got to err on the side. Err on the side of caution.
Most of the cases that have been reported to us that meet our reporting criteria have had malaria. So like 80% of them have had malaria, 1 had Ebola, and the rest of them had Ebola.
So you're not going wrong if you err on the side of caution.
I just had a quick question about the fever temperature. I think it's been revised a few times. It's not something we take in BLS.
So our initial guidance that came out in August suggested that there was a cutoff for fever, and we've taken the cutoff away, so we're accepting subjective fever or any measure.
They're hot.
But we don't actually, they're not gonna You call the provider access line, they're not gonna ask you what the measurement is.
Right.
Yeah, and actually now, you don't have to have a fever and signs and symptoms. You can have a fever or signs and symptoms. As long as it's associated with travel to one of those 3 countries.
I'm just curious, how do you assess a fever if you can't touch the patient? BLS.
You ask them, do you feel feverish?
Yeah, but
Have you had a fever?
patients
Do you
don't
feel
tell you.
feverish? Do you,
Yeah.
then, you know, is it gonna be accurate? No, maybe not. But are they feeling sick? Right, do you have, right, do you have stomach pain, do you have diarrhea, do you have a rash, any of that general malaise stuff? But that's all kind of secondary. The biggest thing is the travel.
Right. but the
If they got
question-
travel to any of those 3 countries, that's kind of our big red flag. That they have some of the symptoms kind of just corresponds to go with that.
The question I have with the travel is one of the questions is if you've been in contact with someone who traveled. I ride the subway every day. How do I know if I've been in contact with someone that's?
Yeah, but if they're not symptomatic.
I'm not questioning
Dr.
everyone.
Quinn said, it's pretty
I thought the
unlikely.
question was, have you had contact with a confirmed Ebola virus disease case?
Have you had, it's more if you, have you had contact with someone that's been confirmed with Ebola or is suspected to have Ebola? Right, for most of our patients, right, riding the train with someone, right, okay, maybe I was on the train with someone that might have had Ebola. What's the likelihood that you caught Ebola from them?
I understand. I'm just saying the question is, I'm almost positive the slide said contact with someone who has traveled. I don't think it said confirmed case, but
Okay,
we'll see.
so it's more along the lines of someone that's either suspected or a confirmed case of Ebola. Maybe the slide might be a little bit outdated.
Well, if you're in contact with somebody who's a confirmed case of Ebola, or who came from West Africa and was handling, doing funeral rites, or handling bush meat, which sometimes we get in this country illegally, but that's something that you may never know. So you have to use what you can see. Do they look sick? Do they feel sick? Did they travel to one of those 3 countries? And up triage, and let them give a call to the Department of Health or 911, and they will make the decision.
And just, I can't speak to ambulatory care or the buses, but for my clinics, and this is not New York City official guidance that's going out to the city. These are the New York City Department of Health clinics that I work for doing safety. We bought all the clinics non-contact thermometers. It's like a little laser gun you can shoot at their forehead, plug their temperature. I don't know if you guys have a budget for that, or it's practical. That's what we did to solve the problem for our employees.
You got a line item for that one?
Do you have thermometers on ambulance?
BLS doesn't take temperatures,
BLS
so,
is
yeah, I know BLS.
So I'll just add that, I mean, one of our other public health approaches to this event that's going on worldwide is that when people come into the country, they enter through the airport, there's screening that happens, they enter an active monitoring program. They're provided with a thermometer, and we contact them daily to find out what their temperatures have been. So yes, it's possible for people to evade that system, but the vast majority of people who are entering the country from there, we know about them already, and we're like monitoring their temperatures, and they have a thermometer. So even what some of the hospital emergency departments are doing is that they'll have a disposable thermometer in the isolation room that they plan to use. They'll escort the patient there without touching them. They'll ask the patient to take their own temperature, and they show them the number through the window. So.
$19 an hour if you want to catch it. Just so you
Next
know.
case. Okay. Our next case is a 58-year-old woman who traveled to Sierra Leone for a funeral for her 105-year-old mother who died of natural causes. The flight returned 14 days ago. After landing, she developed a fever as well as a headache and vomiting. Her temperature upon arrival in the emergency department was 151, heart rate 120, BP 136 over 60. How likely is she to have Ebola?
Just one quick criticism, I don't know if the fire department put this slide together or not, but I think it should be, do you follow protocols or not? Not, is the patient likely or unlikely to have Ebola? Because I think that's where the confusion comes in on these slides.
Well, right now, this is just kind of, this is more formalized. We're
Right.
just trying to gain how your index of suspicion, how you're building it up. All right, so what would be your index of suspicion for this patient to have? Is it high, is it low?
Hi.
All right, it's high. Why would we think it's high?
Because she meets the criteria. She's coming from Jersey on, and she doesn't get it.
And is there anything else that jumps out at you here? How about you attended a funeral?
The few, yeah, there's,
Because many Ebola cases were people contracted because they were handling the dead bodies of Ebola victims. From what we've been told, there's a very high index of transmission and death, so. Yeah. So you're starting to understand, I mean, you have incubation between 2 and 28 days, travel to Sierra Leone, Guinea, or Liberia, and fever and/or other signs and symptoms.
All right, guys, last case. We got a 26-year-old male returning from vacation from Spain. Calls us because he feels sick. He's had no symptoms on his flight, right, or a week prior to flight. Developed a headache after he arrived home. Right, weakness, abdominal pain, and he's got a low-grade fever. He's had it for a couple days now. Not taking any medications, his vital signs are stable. So what do we think about this guy for right now? Yes, no?
no.
How likely? Right? Yes? How likely no? Right? What about now? Prior to flying to Spain, he states he visited family in South Africa approximately 3 weeks ago.
No.
No. Right? Why not?
South Africa.
Not the area, and it's more than 21 days, so we're past the incubation period. All right, so we got two probables and a probably not.
Yeah.
Okay, this is something we pretty much already touched on at July, and issuing alerts about the possible epidemic in West Africa. Giving Liberia and Sierra Leone participants. We already got rid of Senegal and Nigeria. They don't have any more Ebola patients there. One of the reasons that Ebola has been spreading more now from when we had it in the 70s, from what I understand, the villages were more isolated. And so Ebola would decimate a village and pretty much stop there. Now you have people living in community cities, so you've had much more transmission. Go to the next slide, because it's bigger. This just shows you the this is showing you the total deaths related to, we had laboratory confirmed cases of 8,000, and out of those, 4,900 people died. So there's a high death rate. And so about 50%, I thought it was higher than that. These numbers show that. Okay, this is just a timeline, from Dallas, where a patient, Mr. Duncan, who has passed away, in Liberia, on September 19th, went to Belgium. By the 24th, he was having symptoms. By the 25th, he was in Dallas, and he went to the emergency department for fever and abdominal pain. Told the nurses how from Africa, but obviously there was a miscommunication, and he was used. And then 3 days later, he returned to the hospital, put in isolation, he tested positive for Ebola. The EMS crew tested negative for Ebola. They did use
hospitals in Dallas aren't good.
You know, it was a mistake, it was early on, and for whatever reason, they missed him, and he went home. I don't know if that added to his death, that he wasn't treated quickly enough. Who knows, I mean, it's 3 more days. Someone's supposed to pretty quickly. What we did learn is that PPE does protect our providers, these are EMS providers, were gowned up.
One thing to notice on that timeline is that Mr. Duncan, even though he was in the hospital for 10 days, right, he still passed. He didn't make it, right? It was just from being out of that hospital for that first week of having symptoms, even though it was the earliest part of his infection, right? Even though it was only a week before he got to the hospital, and he had all that definitive care, he still didn't make it. So it's of the utmost importance with these patients that they get identified early and they get early treatment. Right? There is no cure for Ebola. All we can really do is support the body in fighting it off itself and giving all that supportive care.
It's like Dr. Spencer now, he released, I think, today or yesterday? Yeah. He got good care, and he was, I just want to reiterate, the Ebola symptoms, incubation is 2 to 21 days. Your average symptoms will start showing in 8 to 10 days, is that correct?
Yeah, so the range of 2 to 21 days, that's like a wide range. Most are gonna present with their first symptoms around 8 to 10 days. So the vast majority, but if we extend the incubation period out to 21 days, we will capture everyone. We will not miss anybody.
And you're not contagious unless you're symptomatic.
That's right, you're not contagious unless you're symptomatic, and also when you your first symptoms are usually just fever, it's like myalgias, muscle aches, feeling not so well. During that phase of illness, you're also not that infectious, even though you are starting to have symptoms. And you're most infectious when you get very ill and have those gastrointestinal manifestations of vomiting, diarrhea, or any hemorrhagic signs. That's when you're the most infectious.
Mr. Duncan, when he was home, I don't believe he lived alone. He had a girlfriend.
There was a family living there, yeah, and actually none of those people became ill.
Because he was at the early part of his illness, did not have a high viral load at the time. It was when he was in the hospital, towards the end, that's when your viral load is at its highest. That's when you're the most infectious, and hence why we had our 2 hospital workers, and unfortunately, they were infected as well.
Did anyone have any questions? Sorry, I'm going fast. Okay, so what do you think is the primary cause of death with Ebola virus?
B.
I heard it over here. It's organ failure. I mean, you are bleeding, you have many different problems in the body, but it's more
I think in this outbreak, only like 30 to 40% of patients have hemorrhage as a symptom. So not all of them will have hemorrhage, but the people who get very ill will most likely die also with it.
And the rash is due to bleeding under the skin, that's like a rash. I think we already went over this stuff. Ebola disease affects cells in the body, the cells die, and organ failure. Pretty much this already. 2 to 21 days after being exposed to the incubation period, not contagious until the first symptoms appear. The current West African strain is 50% fatal, and death usually occurs 2 weeks after the onset of symptoms. Like everyone here has said, it looks a lot like flu. Unless you know where they travel, you'll think of them as a flu patient. Okay, as the virus progresses, symptoms recover. You have the rash again, headache, weakness, muscle joint pain, body diarrhea.
So at the beginning, it really looks just like the flu, right? They'll tell you I'll feel like crap. The latter stages, you get that rash, and you get a lot of the pain that's associated with it. And if they start telling you and they meet that FT, that FT call type that we said before, and they're talking about how they have all this pain that goes with it, the abdominal pain, the joint pain, right, or chest pain, and they have a rash. You're starting to look at someone that's progressed a little bit now. And that's when we really have to be our most careful. That's when they're the most infectious.
Okay. This is infectious versus contagious. I've asked so many doctors what the difference between these words are. Pretty much I've gotten different answers every time. Would you be interested in answering this?
Well, contagious usually refers to like transmitting person to person, and so like something can be infectious without being something that transmits person to person. So like a good example of that would be like Legionnaire's disease, which can be in the environment and can infect people, so it's infectious, but it's not contagious because if I have Legionnaire's disease and I cough all over you, you're not going to catch it.
Thank you. I don't think it's still that important for us at this level. Okay, how is it transmitted? I think you've probably heard this over and over again, just go over again. It's transmitted in body fluids, sweat, blood, either by needles, dirty surgical instruments. We don't have that problem here, I hope. I know that in Africa, they have the equipment, so they don't have any trained medical personnel. And part of the infection is spread because they're not, they're using some needles. You can't transmit it by air. If you have intact skin, you're pretty safe. And coughing and sneezing, like you said, it's not airborne, it's not going to travel that far, so it's probably not.
You'll see all the asterisks next to coughing, sneezing, and skin. That all comes from, in general, it's not infectious that way, but like we said, you have your droplet precautions that was brought up before. If I cough over here, George is probably not going to get it. But if I'm standing right in front of George, or we're nose to nose for some reason, or I'm doing care to him, right? Let's say I'm treating him for something and I cough right in his face, then there's a chance that he can get it. He gets right in the mucous membranes in his eyes and his mouth. And then even on the skin, right? If I'm sweating and George puts his hand on me, yeah, generally he'll be okay. But if he's like some of us that have a bad habit of biting their nails or their cuticles, or let's say, oh, I was doing some work in my house and I was doing some sanding. I don't see I have any cuts, but you know what? When I use that hand sanitizer, it burns. Why does it burn? It doesn't look like I have any cuts.
Your skin's not intact.
Yeah, because you got some breaks in your skin, you just can't see them, right? They're what we call microabrasions. You don't see them, but they're there. So things like that can occur. There are some minor exceptions to those rules.
Are we vulnerable? Well, we didn't think we were vulnerable when we would be going over all this PPE. But as long as you use your PPE, you'll be safe. Okay, the fire department has established their fever call type fever travel. So whenever they get a call, the first question they ask, fever, you feel ill, and have you traveled? And when they say that, they send out their hazard. Regular 911 units will not be dispatched at all.
You guys should be carrying over the same thing to your dispatch like we covered before, like what's in the REMAC advisory, right? We don't want, if we don't have to put our providers at risk at all, let's avoid doing that, right? Identify the patient, identify the ST call type before we even get there. Do it at dispatch. This way you get the appropriate help on the way as fast as possible.
How many of you are the agencies that receive call intake? Are you a volunteer or? Well, if you're an ambulance agency.
Not like 911, no, just,
Yeah, but you have someone that gets phone calls and then dispatches an ambulance. So that's the person that needs to know, how to do the call intake and establish the suspicion for Ebola patients and notify the Department of Health. That's part of the advisory that was sent out, and you have a sheet there that can be printed out and put right next to your call intake center and also on your ambulance.
they should also be able to identify that. Not that any of us have these in our squads, but, you know, those individuals that listen to the radio and maybe buff some calls. Not that that ever happens with volunteers, but they should be able to identify, oh, they went over as an FT call type. All right, yeah, maybe we will let the fire department handle this one.
Okay, when we sent out the advisory regarding how to approach a patient, we based it on what the Department of Health put together, we said it already. You should do this with any patient right now. Try and do your interview of that patient from at least 3 feet away, and establish those first 3 questions: travel to West Africa, fever, and/or symptoms. If you get yes to that, you need to tell them, okay, I'm going to get help, stay right here, back away, go to your ambulance and call the Department of Health. And suit up in case, as we all know, the patient is chasing you or family members after you trying to figure out what you're doing. We need to explain to them that you're going to get help. You don't want to expose yourself. Okay, you're not using your isolation kits for Ebola. We went over that tonight just to refresh your memory. That is not appropriate for Ebola response. The HAZTAC Fire Department, they started out with 10 units. I'm sure they have more now, and they don't do anything except wait for these calls. So we probably have some really happy EMTs and medics that, waiting for these calls. And hopefully we never have to call them, but they are there. And once again, the DOH hotline number, that's a 24/7.
During like regular business hours, it goes straight to like our DOH call center. After hours, the calls go through poison control.
Okay. But there's a person there that will answer the phone.
Oh, yes.
And when in doubt, call them. You don't want to put yourself at risk. That's what they're there for.
Yes.
And, it's better to up triage and make a mistake. Okay. This is fire ops. What they're saying is they send out their HAZTAC, and then they will be sending a BLS unit, and that BLS unit will be there. Because you don't want someone that's gowned up and having dealt with an Ebola patient driving the ambulance. So one of their other EMTs who hasn't been exposed will be driving and be backup. Okay. We don't need to do this. Okay, we did this already. Do you have any questions? I mean, you've probably heard so much about Ebola. Hopefully we'll clarify some questions. Yes?
If you encounter a patient that's unconscious, that may have some of the symptoms, rash, that sort of thing, any guidance in terms of how to interact with those patients? If you're not able to necessarily interview them and get that type of history.
If you're not able to establish that FT call type, right, obviously if the patient's unconscious, you can't interview them. There's nobody else, family members that are around that can provide that information, right? You're gonna treat them like you would any other unconscious patient, right? And if you're not sure, gear up, right? Follow your universal precautions, right? If you really have a high index of suspicion for whatever reason, patient just doesn't look right, let's say they do have some of that external hemorrhaging going on, which, just understand that doesn't happen a lot, then dial the DOH number. We don't want to abandon our patients but we do have to make sure that we're safe. And that's what this is all about, making sure that you're safe first, follow your universal precautions, and get your PPE on. Follow the PPE that we're going to teach you how to don and doff today. And then go from there.
But I'll just add that, this disease is not circulating in New York City. It's extremely unlikely that any given unconscious person on the streets of New York would be infected with it. It's just so unlikely that would be the case. You need to use universal precautions like you would for any patient that you don't have any history for that might have an infectious disease. But I would just say this conversation would go a little bit differently if this disease was circulating here, but it is not circulating here.
So would say don't not treat a patient unless you absolutely